opinions expressed and information provided hereby do not constitute medical advice. It is strongly recommended that you consult your healthcare professional to assess your own health conditions. So huge welcome to Dr. Jemsek, and I'm delighted to now be reading your bio. Everything I have learned, truly learned, in the practice of medicine, I have learned from my patients. Thank you for giving me this opportunity. And that's a quote directly from Dr. Joseph Jemsek. Dr. Joseph Jemsek, MD, received his medical degree from the University of Illinois Medical Center in 1974 and completed his infectious disease fellowship at the Baylor College of Medicine in Texas in 1979. In 1983, while working at the hospital epidemiologist in North Carolina, Dr. Jemsek diagnosed one of the first cases of HIV and AIDS in the States. And he dedicated the next 20 plus years caring for this stigmatized population, involving himself in clinical research projects and testing of breakthrough new drugs. In 2000, Dr. Jemsek opened his solo practice, planning to dedicate the rest of his professional life to AIDS and HIV. But soon, an influx of patients from all over the United States started flooding the Jemsek Clinic. These patients were complaining of symptoms of chronic Lyme disease. Little did he know that this was the start of an unlikely story in which the patients would shape the specialist, changing the course of Lyme disease treatment and Dr. Jemsek's own life. For the next 25 years, Dr. J, as he is affectionately known, dedicated his practice to patients with tick-borne illnesses. The Jemsek Clinic in Washington, D.C. became a destination practice, welcoming thousands of patients from 50 US states and more than 40 countries. Dr. Jemsek evaluated over 15,000 cases of Lyme disease and other tick-borne illnesses, and introduced dozens of pioneering treatment innovations. Dr. Jemsek is a past member of several medical organizations, including the American College of Physicians, the Infectious Disease Society of America, and the International AIDS Society. He served as treasurer to the International Lyme Associated Disease Society from 2008 to 2011. He's been a keynote speaker and presenter at several international medical conferences and scientific meetings, including Duke University, the UK Conference on Tick-Borne Diseases, Live Lyme Foundation, the World AIDS Conference, as well as numerous ILADS annual scientific conferences. In 2005, Dr. Jemsek closed the Jemsek Specialty Clinic after 50 years of service to thousands of patients. Dr. Jemsek transitioned from practicing medicine to focusing on patient advocacy and advancing the public's understanding of tick-borne illnesses. So thank you so much, Dr. Jemsek, for joining us here tonight. We're all incredibly excited to see your presentation. And now I will hand over to you to continue. Thank you so much for being here tonight.
Thank you, Marvin May, for such a very nice introduction, and welcome to the audience. And I know that we have a special audience who has a special interest in this dreaded disease. It's a very complex disease. So we have a distinction of Lyme disease, which is an acute curable disease, which is what hit the textbooks in the 70s and 80s, primarily the 80s. But then over time, it evolved that some people weren't getting better. And when I started seeing this disease 23 years ago, at some point I gave it the moniker Lyme borreliosis complex, because after working with the disease for a while, I recognized that, it's more than a spirochete, I think. I think it's, some other pathogens. And now why they got together and what was the etiologic pathway or mechanism is poorly understood. It's also a very vaguely and politicized, and therefore even further misunderstood disorder. It does require specialized treatment, and I'll give you a hint of that as we go forward. I choose the term complex. Lyme borreliosis is used in the vernacular more and more. Why complex? Because it is polymicrobial, in other words, a number of pathogens. It's immunosuppressive, not like my HIV patients, but it's immunosuppressive. It's multisystemic. It has an incredible reach in the human body. And it particularly has a proclivity and affinity and tropism for the nervous system, unlike any other chronic illness of which I'm aware. So that it can be present in any part of our nervous system, which is quite frightening. So let's talk about polymicrobial disease, and I won't get into each of the pathogens, but there are a half dozen different pathogens, one of which consists of the Borrelia species with its multiple strains, and it also has the side benefit of having multiple life forms, so that it's not just a simple spirochete that wiggles around. You can catch it if you know how. It's much more clever than that. It lives inside cells, outside cells, in virtually every tissue of our body, can adjust forms on the fly, can go into a spore form or cyst form, like when it's under pressure, whether it's physical, chemical, or antimicrobial. In 2004, Singh and Embers independently published brilliant scientific papers that showed how evasive this organism was. They didn't speak about the immunosuppression, but they did refer to it because they're both immunologists and microbiologists. But it has survival mechanisms that I wouldn't say overwhelm the immune system, at least not right away. They play the slow game. They escape and they exhaust the immune system, and they have many mechanisms to do this. As an infectious disease person who did HIV/AIDS, naturally I was looking at immunoglobulin levels, which is IgG, IgA, that sort of thing. Some of you may be familiar. Lymphocyte levels, which I've done thousands, tens of thousands of tests. And to my surprise, I found that these were not uncommonly low. Not as low as with my HIV patients, but they were low. So here's a clear, palpable, measurable sign that we have an immunosuppressive illness, in my view. Multisystemic disease, I've just mentioned. In 2006, Dr. Livingood published in the New England Journal showing that she did monolayers with 30 known types of neural cells, and they were incapable of invading and killing virtually every cell. And then other studies have corroborated that not only are they capable of killing every type of cell we have in our nervous system, but also can invade every other cell type we have: fibroblast, myocardial cells, endothelial cells, what have you. And they even invade our immune system. Tropism refers to the attraction of an organism in a lock and key mechanism to a cellular membrane. So this is not a hard and fast rule in infectious diseases, but it's pretty much the rule of nature. And then multi-compartmental neurologic disease, as I've said, Livingood demonstrated that the spirochete affected all neurons, support cells, which are called glial cells. And then there's a high prevalence of neuropsychiatric disease, which is, you have to wonder, is this contributing to our worldwide recognition of increased emotional instability and emotional chaos? One just has to wonder. You hate to just default everything to Lyme, but it's sometimes not very hard to do that. This slide describes in general terms the fact that testing is not adequate, either for diagnosis or presence, but also as a marker for the status of the infection. So I was very spoiled prior to dealing with this illness, because with hepatitis B, hepatitis C, other chronic illnesses, by the way, other chronic infections, and with HIV, also a chronic infection, we had tools that said, oh, we can measure how much of the pathogen is available, and we can do a quantitative analysis, and it's so-and-so, and you're in remission or it's under control. Not so with Lyme. So it's just another obstacle, another element that makes it more difficult for everyone concerned, a provider and patient, to deal with. So I've come up with a clinical triad, which is encephalopathy, arthritis/enthesopathy, and then polyneuropathy/mononeurous multiplex as major criteria. Now, having said that, I think everyone listening understands that there are far more manifestations of this illness and numerous more, but those are minor criteria in my view, and there are literally dozens, if not hundreds of them. But these are the three major categories I use for purpose of trying to understand this disease myself even better. Encephalopathy is inflammation of the brain. The brain's a big place, has many compartments, but you can have things such as headaches, hallucinations, seizures, jerky movements. You can even have loss of consciousness, sleep disorder, and these are all pivotal life functions that are disturbed. So it's almost like you're working on a scaffold, and this disease is pulling pieces of the scaffold down one at a time. First it makes you a little bit, it makes it difficult to communicate. It makes it hard for you to express yourself, hard for you to understand, to read, to comprehend, can frustrate you, and things can spiral. It also doesn't help you make new friends. And then sleep is another one. Sleep, very important. We all need our restorative sleep. We need that critical delta sleep in the early part of the sleep cycle. And this disturbs that. So it's like pulling pieces of the scaffolding away. Mood alterations, irritability, and depression. I have this little metaphor. I like metaphors. And I have a Lyme mood hotel with 4 stories. And I won't get into all the details of it, but the first story is irritability. Everyone that enters into this hotel is irritable, 100%. Everybody is a little snappy, a little rush to judgment, little opinionated maybe. I can't be wrong. And on the 4th floor, we have raging psychosis. So you can imagine what's in between. And then finally, but not less importantly, cognitive changes, including memory loss, confusion, and poor attention span. I think you can see how all this conspires to totally deconstruct the human persona. The second part of the triad is arthritis and enthesopathy. Arthritis is, of course, joint pain, swelling, stiffness, redness, decreased range of motion. However, if somebody says they have joint pain and you say, well, your joint's not swollen and it doesn't look red or anything. Yeah, but it hurts like the dickens. It really hurts. And when you examine the patient, you actually do compression of the metacarpals, metatarsals, wrist, shoulder, what have you. You'll find that there is some tenderness. You also find in fact, that the tendons and ligaments are inflamed. So you have a situation in which not necessarily the arthritis is present, the joint itself is inflamed or has fluid, it's warm, but it certainly is tender and certainly is uncomfortable. So inflammatory would be arthritis, non-inflammatory would be enthesopathy. Symptoms tend to be migratory, but this is not a hard and fast rule. And finally, we have polyneuropathy or mononeuritis multiplex, pain, numbness, tingling, burning pain. I would say 95% of our patients, when tested with a simple bedside test, will have loss of sensation at the ankle, which is the longest nerve, is the sciatic and sacral nerves to innervate they're furthest away from the spinal cord. And so they may have pain, of course, they may have numbness and tingling, of course, or they may just find that they're not as steady as they used to be. And these things tend to be progressive. And of course, you can go much further. The nerve roots extending from the spinal cord, if damaged, can cause weakness in any part of the body, depending on where the damage is. And this can cause movement control and partial paralysis even. And then in our spine, off the spine, we have, as the nerve roots begin to form, we have ganglion, we have plexi, which are a collection of ganglia. And these can be inflamed as well. So you can have a whole sacral plexus involved, for example, sacrum being at the bottom of the spinal cord. And that can involve your bladder, bowel, your genitalia, and all that sort of thing. And things can go south and the urologist or the gastroenterologist may have no idea when in fact it's neurologic in nature, caused by our friend the spirochete. Borrelia infects virtually everyone. You should also understand that doesn't equate to disease expression. That doesn't mean everyone has Lyme disease. So like the herpes virus family, infection with BB is permanent, but Babesia is critical to the clinical expression of LBC. It's immunosuppressive and likely associated with the expression of a host of other chronic illnesses, all the neurodegenerative disorders, rheumatic diseases, inflammatory bowel diseases. Maslow's hierarchy of needs. This was proposed by psychologist Abraham Maslow. It's controversial and it is flawed, but I think it has some use, so let's go through it. In Maslow's theory, if you start from the bottom of the pyramid to the top, we have 5 steps. So we have physiologic needs, basic survival requirements. We have safety needs, which are security, stability, our health. We have love and belonging. Humans benefit from social connections, friendship, family intimacy. We have esteem needs as we go up the hierarchy, as we are able to achieve more in our human condition and through our lifetime. Self-respect, recognition, competence, appreciation. And then at the top, we have self-actualization, which is, you've won the lottery, you've done everything in your life, you're the best person ever. Where's our Lyme patient in this? If you give this any credibility, even though it's a crude way of presenting this, our poor patient with LBC is stuck in, they're not at 4, they're in 2 and 3, is what I see. Now, I have people who have been in 4, maybe even 5. But this disease will erode your capabilities, your confidence, your self-awareness, your ability to communicate, your ability to create, advance in your career, and so forth and so on. So people slide. So I've seen so many well-accomplished and well-educated people, and they struggle, and it's very frustrating for them because it's frustrating for everyone. So they slide down and they're trying to get back to self-respect and recognition and being competent. And so it's a slippery slope. Again, as symbolically demonstrated by this, the side of the pyramid. The protocol. Treatment steps. We have this beautiful spiral staircase that my colleagues created. Evaluation, stabilization, treatment, healing, and remission. So the treatment is structured, but it's always individualized and frequently adjusted. So I did that just common sense. We're such a diverse disease with an incredible spectrum. You can't put everybody in a cookie cutter. When we stabilize, we focus on issues affecting their basic situations. You have to understand from the patient and from their support person what their basic life functions are. The patient will sometimes be unable to tell you, or being disinclined to tell you, or forgot. And then when we stabilize, we understand we're dealing with a patient whose body is chronically inflamed. That's not fair. It's not a fair fight. Our bodies aren't supposed to be chronically inflamed unless we're dying. And that's what's so hideous about this illness. So we go through techniques to reduce inflammation. Well, I guess we'll get to that later. So with treatment, we select targeting of pathogens with strategic use of herbals, antimicrobials, pulsing. I use pulsing because these are slow-growing targets, and they're multiple targets, so we don't need to treat every day, and take advantage of that. It's like when you up against an adversary, you need to know the weaknesses and where your opportunities are. And again, this is a battleground, so this is a strategy. You gradually allow for immune reconstitution. This is the most important bullet in the program. This is all about not how many drugs Jemsek can give you, nor how many herbals that I'll allow you to take. It's about getting your immune system to reconstitute, so the better you do, the less I do. And part of that includes, there are many subtle aspects and nuances to it, but part of it's coordination of synchronized degradation of biofilm as you go through therapy. Maintenance and recovery takes 15 to 18 months in the best of cases. So we have already induced changes in lifestyle that are basically, the bottom line is that we're going to a low inflammatory lifestyle. And then as I intimated with the treatment, we want to take away the neurotropic and psychotropic augmental therapies that were necessarily employed because of the severity of the patient's symptoms, which were debilitating and which were not going to allow us to see immunologic recovery simply because they're constant stress. So POEMS is there adequate pain management, not getting rid of the pain. O is for other or various roadblocks, so it's kind of our catch-all, but it's mostly social support. E is for endocrine and metabolic issues. If somebody got raging testosterone issues, or more commonly low cortisol issues, like, if somebody has a Addison crisis, they're not going to be, they're not going to do well. They're going to end up in the emergency room without a blood pressure. Mood and psychiatric issues, obviously, they have to be on the playing field. If they're having debilitating psychiatric episodes of any kind, then they need to be stabilized. And then sleep, we've already spoken about. Self-help. So a few years ago, Natasha and others with LDUK were instrumental in working with me, and they did all the work. I just provided some of the concepts, but they did all the work. And you've got your manual that I believe is going to be upgraded and be available to the audience. But it's wonderful. I wish I'd done the same thing in America. So there are a few things everyone can do without access to care. Everywhere in the world, access to quality care is rare. We have this huge paradigm where, and huge disconnect where we have millions of patients and we don't have millions of providers, to say it one way. So we all have to fend for ourselves, but there are some basic innocuous things you can do. So one of the things we want to do is, if we can get the inflammatory quotient down, then let's do it. Why do you think, to ask a rhetorical question, why do you think there are billions and billions of dollars in sales for supplements in our world today? I'll just give you a very simple cocktail. This is not the only cocktail of the many hundreds of combinations, and they're all put together a lot of times in a formulation that comes out and says, oh, we've got the new best feel-good combination. They're using all the usual suspects included. So anti-inflammatory cocktail. If you had to pick three, I would say fish oil, curcumin, and vitamin C. And then magnesium, a good magnesium product such as glycinate or threonate is very good for any kind of nerve pain, restlessness, should be taken in higher doses, and these particular products are not diarrheagenic. Dietary choices, cut off the head of the snake, don't put gluten in your body because 90% of the time it's pro-inflammatory. And then you just have to decide by your diet that there may be other offending foods. Now, I recognize that many people have exquisitely sensitive guts and food intolerances. So, I can address some of that later, but for general information, this is something everyone should know about. Detoxification, we need to sweat. We can do it passively if you're not able to move your body with a warm salt bath. Drink some hot green tea before you get in the bath, and that will help raise your body temperature. You can have a little sweat. What we want is a little sweat. Same thing for a sauna. If you happen to have an infrared blanket, or if you have your own unit in the home, drink some warm green tea. I say green tea because you want the warmth, first of all, but the green tea is about one of nature's best antioxidants. And then if you can be active, you can be stretching because that's going to mobilize the lymphatics. You can do aerobic exercise, maybe not as much as you could before, but anything to generate a sweat and get the lymphatics moving and dumping out toxins. Having support is crucial. I can't emphasize that enough. You have to have somebody on your side. If you're not in a good mood and you're not very nice to people, sometimes people don't want much to do with you. So it's an issue. I don't have an answer for that right now. To summarize, the emotional and cognitive components of this illness are immense. Much like a patient diagnosed with a malignancy, an LBC patient goes through the classic stages of a grief reaction, denial, anger, bargaining, depression. You may sometimes feel hopeless. You may have been beaten to a pulp by the disease and the medical system, but don't give up. keep searching for a way to support yourself and fight the good fight. Thank you.
Thank you so much for that. That was absolutely fantastic. It was really fascinating. And I think we've all come away having learned something. So thank you so much for that. If you would like to receive updates about Dr. Jemsek's work, you can sign up for his newsletter, Choose Life Over Lyme, where he'll be sharing over 25 years of insights from his work of decoding Lyme disease. And you'll also hear about his upcoming memoirs. Before we move on to the questions, I'd just like to remind everyone that the opinions expressed and information presented hereby do not constitute medical advice. It is strongly recommended that you consult your healthcare professional to assess your own health needs. So the first question that we have is, after a significant period in remission from Lyme disease, a treated patient should start to feel the onset of new symptoms due to a weakened immune system. How would you treat that relapse? Would it be with antibiotics? Is it likely that it would be more difficult to treat that patient?
I think it's actually, if you have a good relationship with a physician or provider, I should say, that got you better, you would first look at, okay, what caused, what were the stressors that may have led to the relapse? And as a caveat to that, or as a corollary to that, I would say relapses are very common despite our best efforts. So we're just not good enough to keep people in deep remission even after several months of intermittent therapy. But I'm very confident we can get you back in deep remission. It's usually a function of the Babesia coming back. And so you understand that in infectious diseases, we need our immune system on site, involved to help us with pathogens. We can't just give chemicals and expect that everything's going to be all right. In the end, it's all about immunologic control, particularly in the remissive state. So when people relapse, we're dealing with such a complex set of infections that the immune system, by which the immune system has been diminished, it takes a while for it to reconstitute. It really does. It probably takes 3 to 5 years, quite honestly. And also, the advantage you have if you relapse is that you've learned how to live a low inflammatory lifestyle. And in doing so, you put yourself up for success because you know what works, you know what you need to do, you know you've been spanked if you go out and do something you weren't supposed to do and you have symptoms. There is also a phenomenon of people who have been so terrorized by this illness that once they finally do get better and get some what I call blue sky days, blue sky weeks, and blue sky months, and blue sky years and so forth, if they feel a symptom coming back, they're horrified because they feel they're going to go down the same pathway. That's rarely the case. That's rarely the case because your immune system by that time, having had some success, is going to be at such a better plateau and starting point.
Thank you so much for taking your time to answer that. And the next question we have is, in a recent talk, you mentioned the idea of returning to Babesia at the end of treatment, bookending, to attain a more lasting remission. What are your thoughts now?
Well, this is an educated question. I congratulate the questioner. They know something about me. My Babesia program is complex. It seems onerous to some people. There's so many medications you have to take, but it's just such a hard co-infection to get by. And I do think it's the I think it represents the crux of the illness. I really do. If you go back to my concept that I think everybody has Borrelia, well, what converts them to some of the major microbiologic things that convert them to a disease state? And I think Babesia is uniformly present in people that come in with, quote, chronic Lyme or LBC. So my patients were so happy to get back together, but then even though they weren't nearly as ill, I'd be seeing relapses in about 30 or 40%. maybe 3 months later, maybe a year later. And then since I do careful exams, I would notice that the liver would be enlarged again, and the spleen was again enlarged. And that's a hallmark of a Babesia infection. And many years ago, I realized, oh my God, the liver's back, the spleen's back. Are you okay? Well, not really. I started having occasional sweats and that sort of thing, or kind of going downhill. And I found that I needed to retreat babesiosis. Well, I did this for a while with success. But then I thought a few years ago, why not just retreat people? They've gone through all this, the program of 12 months or 15 months. And I said this to 150 people. I said, okay, I'm going to retreat you. I believe that your chance of relapse are going to be greatly reduced. And no patient said no, not a single one. And honestly, in a series of at least 100 people in which I did that, I have to say that I didn't see a relapse. I feel very confident this was a huge step forward and a very efficacious thing to do. And I appreciate the question.
Thank you so much. So our next question is, it seems that my symptoms get a lot worse before my monthly cycle. Is this common, and why is it so?
Yes, it's common. We know that the arachnoid's system is very active and generates prostaglandins, which spike at the premenstrual period of time when the estrogen is dropping and progesterone is coming up. So estrogen is anti-inflammatory in general. So that's why some, not all, but most women during pregnancy will feel better. In fact, I've had a few ladies saying, I just keep getting pregnant because that's the only time I feel good. And then I have the baby and all hell breaks loose. But yeah, so it works. So if you can't find a gynecologist, or if it's contraindicated to use BCPs, we use anti-inflammatories and fish oil, and we try not to cycle our therapy for that month, during that particular time. So we'd adjust our treatments timing, because after all, I don't treat all month long. I treat for several days a month.
It's really helpful to know. And our next question is, what would be the single piece of advice that you would give to a caregiver with a family member suffering from chronic Lyme disease?
That's a great question. I think I tried very hard so I always would identify who was in the room. I wanted everybody's name before I went in there. I wanted to know what their role was. I wanted to know how many caregivers the patient had, because it's a lot to ask just one person to do it, but sometimes that's what there is. Bottom line is, if somebody didn't have an adequate or a dedicated caregiver, it's very hard to get that patient better, if not impossible. And that was a basic criteria for getting in treatment with me, was you have to have a caregiver. The caregiver, and there were a lot of dynamics with caregiving, but let's say we're working with a genuinely good person, a caring person. I'm sure St. Teresa got tired in Calcutta. And I recognize that. I mean, if you're dealing with a person who's out of sorts, is high demand, never particularly happy, doesn't give a lot of gratitude. Now, that's not always the case, but it can be. I would try to make a point of just thanking the caregiver and saying, look, I know it's so important what you're doing. I appreciate it so much. And do you guys have any other help? And I would always say it in front of the patient. I said, what you're doing is really, really important to the patient's care. So I would say to the caregiver, you love this person, you're devoted to this person, but love has many different faces and flavors, and we all have limits, and I just want you to know I appreciate that. On the other hand, your care, or the care of others in conjunction with your care, is extraordinarily important.
That's such good advice. Thank you so much. I know a lot of people in here are caregivers, so I know that'll really have touched a lot of people. Thank you so much for that. Our next question is, I had Lyme disease and went into remission, but then got long COVID. Lyme symptoms have returned. Could long COVID cause a relapse of Lyme? Could acute Lyme disease treatment work in such cases?
So yes, COVID is So as an anecdote, I had a number of patients who hadn't seen for 2, 3, 4 years, 5 years, say, hey, I got long COVID and I've got some of the Lyme stuff back. And that taught me two things. One, it's a very potent stressor, obviously. It attacks some of the same human pathways in the nervous system and so forth, and reactivated. It also told me that, oh my God, Lyme is just resilient as hell. And they've been living their life doing well, but it came back. Now, fortunately, it was easy to put back in remission, so I didn't have to go through a whole 15-month program with them.
Thank you so much for that. And our next question is, would you ever consider programming a dedicated AI to guide patients and doctors in the Jemsek protocol as your legacy?
To be determined. You're talking to somebody who didn't want to learn computers in 1999. So
that'd be quite an ambitious thing.
I am a dinosaur, but I also, this is the next technological age. We have the computer, now we have AI, and before that we had, the industrial age and all that. So, AI is upon us. It's not going to go away. Like a lot of people, I have concerns about it, and it's controlling or replacing human nature, but I don't think it will. I really don't think, for example, my colleagues and I have discussed this. Who knows? But I think it will take generations before AI replaces the human touch. Let's wait and see. I mean, I have some other projects before that are more salient and more hands-on that we need to get through first.
Absolutely. You've got your very exciting memoir coming up, which I'm sure is dominating a lot of your time at the moment. So our next question is, what is your approach to treating patients with chronic Lyme and co-infections who have significant medical hypersensitivity, including mast cell stabilizers and supplement and herbal treatments?
That's a tough problem. So that in the same category of people that can't take any medications, they've had all these effects, some of which are Herxheimer and so forth. So we have a very difficult disease with its own very difficult spectrum, and of course, at one end of the spectrum, we have the most difficult. And dealing with histamine, and which is a individual's way of showing the inflammation, where histamine dominates the landscape. And so it becomes all about histamine. And so mast cell became its own thing, and histamine became its own thing, which okay, why are we having all this now? Where was this 20 years ago? Most people are familiar with the basic approach. You learn which foods are the highest in histamine. You understand that there are different groups of medications that are capable of being paired together. One particularly important product is DAO. I think, are you familiar with DAO? Yeah, so it used to be made just by one company. It was porcine, and I understand there's another group of companies that are making from legume derivations, so peas. So it gets rid of the porcine intolerance, so that's good. So DAO, diamine oxidase, is a simple little enzyme found in our gut which breaks down histamine and converts it to histidine, which doesn't have the pro-inflammatory. Now, histamine is it's like everything else in our body. Everything should be in balance. Histamine is not our enemy, but when there's too much of it, it is. Because histamine is actually pro-inflammatory, helps the immune system, until it gets out of control. Even probiotics can produce histamine. So you may have somebody say, oh my God, whenever I take VSL1 or something like that, I get a histamine reaction. And it turns out that some of the probiotics promote histamine release. So it's just kind of like, there's no winning for losing. So then you taper back your probiotic, and we did have a list at the clinic of, a gradation of probiotics that would be safe to start if you have a histamine issue. With gentle treatment, with gentle introduction of this or that or the other to stabilize, we have seen people stabilize and be able to tolerate and eat some of the foods that they haven't been able to eat for some time.
So our next question is it possible for Lyme to go from attacking neurological systems to attacking the joints? If yes, could it go on to attack the heart?
It can do any sequence. It can do any combination of all the above involving all of the systems, with a predilection and tropism for the neurologic system, which is the most sinister and hideous thing that it does. But yes, it can do anything.
Thank you so much for answering all those pre-submitted questions. It's been an absolutely fantastic session tonight. We really, really do appreciate it. And I'm now going to hand over to Natasha, who's going to do a few closing sentences. And thank you everyone for joining here tonight and for all your incredible questions as well. So over to you, Natasha.
Thank you so much. And hi, everyone. For those of you who don't know me, I'm Natasha Metcalf, the co-founder and chair of Lyme Disease UK. And wow, what an evening it's been. Thanks so much, Dr. Jemsek, for the incredible presentation and session. I think it's safe to say that we've all learned a huge amount, and you're honestly such an inspiration and a complete hero and legend in our world. And you're very important to me personally, having saved me. So thank you. And also, we can't wait to see what you're doing next. Honestly, we're going to be completely tuned into your newsletter, your memoir. We can't wait, and we're massive supporters over here. Also, a huge thank you to Morven May for facilitating this evening session so beautifully. And also to Zoe and Jean on Dr. J's team, who've been working so hard behind the scenes to prep for this event. A big thank you to Joe, our communications manager, who's also been working closely with Jean and Zoe and Dr. J to pull off this evening. And also thank you to Paul for all the technical support and video recording and editing so that we can share this presentation online afterwards and reach many more people. Finally, thanks so much to all of you for attending this evening. We know it takes guts to come and ask your questions and show up, especially when you're feeling so ill. And we really are grateful for all the pre-submitted questions as well. As you probably know by now, we receive national lottery funding for these sessions, which we're really proud of. So please stay tuned for future sessions as well. We really hope to see you again. Also, Dr. J, we hope to have you back again if you can bear it. We'd love to have you as a regular guest.
Great questions. I have no problem with the great questions. Just great.
Thank you, and good night, everybody.